So we're going to take the patient. Hopefully, if we can't resolve that clot, then the patient needs to go to coronary cath lab for a percutaneous coronary intervention. So if there's enough time to do these things, this is hopefully what we'll do if we have a lot of time. Otherwise, we may have to rush the patient to coronary cath lab. So as much as possible before they go to cath lab, they should be NPO. Sometimes that's not possible. Hopefully we'll be doing an EKG. We can at least get an EKG in the ER. Sometimes the patients are admitted directly to the coronary cath lab. Prep the patient's leg, meaning we're going to go through the femoral artery, so we need to shave the leg of hair, get it ready for prep for the procedure. Some doctors do the procedure going through the radial artery in the arm. That's not near the recovery process as through the leg. If the patient's very anxious, maybe give them some Ativan ahead of time. They should sign a consent form. If they can't get it signed, the doctor will sign it if it's an emergency. There's a video usually that they can show the patient what to expect. Nurse needs to explain the recovery period, answer any questions, pull labs. Some of the stuff may be done very quickly. Some of it may be done in the cath lab before they start, like prepping the leg, giving them the Ativan, signing the consent form, answering questions. Pull blood for lab, that may be done very quickly and they're not even waiting. It's got to be done in emergency. Remember, quicker you can get the patient and open up those coronary arteries, the better it's going to be. So cath lab, coronary cath lab. It is done under fluoroscopy, so we can actually see real time what's going on. The patient's going to be heparinized. They're going to be put on a heparin drip. You need to have lots of heparin on board. That's why it's a drip, so the patient doesn't form clots during the procedure. They put a giant catheter in the patient's artery, and basically this is what they're going to feed the lines up to actually get and look in the coronary artery. They're going to shoot some dye. One thing they are going to do emergently is find out what the patient's creatinine level is. Creatinine level is an indication of your kidneys, how well your kidneys functioning. If you have high creatinine level, shooting more dye is going to knock out some function of the kidney. You don't want them to completely be blown out and you're going to be on dialysis, but certainly that is a risk if you have a creatinine level to begin with. So once they shoot the dye, see where the blockage is, they may insert a balloon and do an angioplasty or put the stent in. Now, I said previously that somebody may have 75% blockage to have heart pain, chest pain, angina, but they need to have greater than 85% closed to put a stent in. Although, as I say that, there was a study done this summer that basically asked the question, why are we waiting till patients have 85% or greater closure in a coronary artery to put in a stent? Why can't we put stents in patients' coronaries if they are 75% blocked or if they're 70 blocked? So that's a question they're asking, trying to find out if it would be prudent to do that. So patient may also be placed on a glycoprotein 2B or 3A inhibitors. A good example is integralin. This stops fibrinogen to clump with causes that not to be formed, so we won't form clumping platelets after the procedure. This was used a lot previously. It's still used, but that's another option after patient goes to cath lab. So patient goes to cath lab, they shoot the dye, they either do a angioplasty or a stent. They can do both of them. They'd like to get the stent in. Coronaries stay open longer if you use a stent. So there's risks though when you have an angiography. The risks are you might not be able to open the coronary artery. If you can't open it up, then the only way to stop the pain and also get blood flow is you may have to do a coronary artery bypass graft. Rupture, when you put the wire, the guide wire up there, you may rupture a coronary artery. If you do, you have to go immediately to bypass surgery so you don't bleed to death. It's a risk, but there are some patients that code during coronary artery, coronary during the coronary catheterization. Patient may have triple vessel disease, meaning they may find it's not just one artery causing the pain, it's three of them. These patients usually have to go to coronary artery bypass, so there are risks of having an angiography. So recovery period after going to coronary catheterization lab. If the approach of the heart is done through the femoral arteries, the patient needs to stay supine for many hours, anywhere up to 6-8 hours without getting out of bed and moving that right leg or left leg, whichever one the doctor used. So they have to stay down so long because, number one, it went through an artery. You don't want to cause a patient to bleed to death. So they need to stay down. You need to wait for the body to absorb the heparin. The heparin is always going to slowly work out of the system. It depends. Some patients absorb and break down heparin faster than others. The test we do to find out the heparin result and find out if you can pull that giant catheter out of the leg is we do an APTT, activated partial thrombotime. You need to remove the sheath. Patient has to form a large clot in there. Patients sometimes come back from surgery or from the cath lab, instead of the sheath in, they put in a closure device. Closure devices are terrific. Patient can get out of bed a lot earlier, but they tend to leak and ooze blood. So all these things are part of the recovery. A lot of education. Patient's going to be on new medicine. So possible medications. From here on out, post-op, the patient will probably be told you need to take an aspirin a day. They may be on Plavix. Plavix is a form of adenosine diphosphate receptor antagonist. So clopidogrel, Plavix is a common one. Patient may be on nitrates. They might have coronary chest pain, heart pain from here on out. So just to keep the arteries dilated, maybe a extended release oral nitrate. Example of that is Iserdil. Patient should be on a beta blocker. Beta blockers reduce the afterflow, it reduces your blood pressure, it helps the patient's heart not work as hard, so that will reduce chest pain, and also the heart does not have to work as much. A lot of these medications will be determined by how much damage is done to the heart from the MI. Another medication I mentioned before is a beta blocker, like a Lopressor, metoprolol, or they could be using a calcium channel blocker. A good example is Cardizem. Reduces your heart rate, contractility. ACE inhibitor. ACE inhibitors stop vasoconstriction in your periphery. A good example of that is lisinopril. These are all medications that a lot of post-MI patients are on. Most are on at least one or two or three of these. So, patients had an MI. Now, let's say we have a patient out there that they've had an MI, or they're going home now. They have been through that whole process of cath lab, or maybe they've had bypass surgery even. So a lot of these patients are now classified as chronic stable angina. They may have chest pain the rest of their life because of the heart damage. So anything they do exertionally may cause chest pain. Well, they know, they're going to learn that they need to stop when they start hurting, or they're going to always carry nitro pills with them. So, they need to back off on work, stress. They can take nitro. They may be using nitro paste. These are patients that really need to do something about the modifiable risk factors, um, things like that. So, um, some patients will have chronic stable angina. As long as it goes away when they stop doing something, then these patients are okay. They may live this way forever. Um, so other complications from a patient having an MI is, some of them are, um, most serious complication is you have a MI and you go into cardiogenic shock, meaning you have destroyed so much heart damage the heart cannot function as a pump anymore. You're not getting enough blood perfusion. Cardiogenic shock is very risky. 85% mortality rate for patients that go into cardiogenic shock. In the meantime, for someone that goes into shock, we can put them on what's called a balloon pump. These patients usually go into cardiogenic shock because they had an anterior MI, so their cardiac output is really low. They probably lost 40 to 50% of their myocardium. So these patients really, if they can make it through cardiogenic shock, they may have a very disabled life as far as doing anything because their heart's not going to allow it. Another risk is thromboembolism. So if you don't have really good blood flow, or the MI caused a lot of damage, you may have risk for clots the rest of your life. Another risk is you could have ventricular rupture. It's the least common complication, but that can happen. It's usually with lateral MIs. Most common complication is you're going to have some kind of dysrhythmia. So it'll change your rhythm. You might have a heart block. You might be in AFib or a flutter. It may damage your valve. A lot of different things. It may cause pericarditis, so an infection of the pericardial sac. You may have accumulation of fluid in your pericardial sac. So that has to be monitored. You might rupture your inferior wall or destroy your papillary muscle. You could go into pulmonary edema. You could go into heart failure. You might have heart failure forever after having your MI. So now you've got a bad heart, but now you have heart failure, and you'll have to watch all of your intake and output and your salt intake, and you'll take medications for that. So let's do a few questions. Client with unstable angina receives routine application of nitroglycerin ointment. The nurse should delay the next dose if the client has. What's the right answer? Nurse is caring for a client with a diagnosis of hypertension. The nurse concludes that which of the following outcomes indicates successful treatment for this client. Select all that apply. When educating the client with essential hypertension, the nurse instructs the client to do which of the following? The nurse is caring for a client admitted to the emergency department with chest pain. He reports that chest pain developed while mowing the lawn, and he stopped and rested, as is typical. This time the pain was not relieved by rest, so he came to the ED. The chest pain is relieved following administration of 2 sublingual nitroglycerin tabs. Nurse draws which conclusion about the patient? You are working in the ER. Patient arrives complaining of substernal discomfort for about 3 hours. Labs are drawn. Which one will be most useful in determining whether you should anticipate acute coronary syndrome orders? You evaluate a hypertensive patient who has been taking Vasotec for 3 weeks. Which data indicates you should contact the physician?